Thank you very much, Martin. Thank you, Guilherme, for giving such a nice introduction to our discussion here. So we have this big dilemma as to whether go direct or to bridge, and that's what is going to be discussed here. So here are my disclosures. So again, direct or to bridge. Let's dive into the past. The neuroendovascular treatment tends to follow the footsteps of cardiology. This is a question that has been addressed by our colleagues, and when they look into facilitated PCI, meaning PCI with the use of reteplase plus minus glycoprotein 2B3 inhibitors, there was no benefit in the adjunctive treatment with the intravenous drugs in relation to the endovascular treatment alone. However, it's important to acknowledge that they face much more frequent and atherothrombotic issue versus us. We have embolic issues in over 90% of the cases, specifically in this side of the world. The past enforces that the use of intravenous thrombolysis should be performed in every single situation that the patient's candidate, and this applies to both the ESO ESMINT guidelines and the AHA guidelines with the highest possible level of recommendation. But now you have the present. And before you discuss this data, right, these trials, I think one of the most important things that we need to highlight is that these data, they are not applicable to most settings. What you are talking here about to bridge or to direct MT, okay? It only applies to very specific scenarios. It's a scenario of a thrombectomy capable stroke center that, by the way, has a fast workflow and the team is immediately available to perform the procedure. So these studies, these data, these guidelines, they do not apply to any primary stroke centers. They do not apply to any thrombectomy center that doesn't have a fully optimized and fast workflow. And they do not even apply to well-oiled machines, very fast, good work centers, if the team is not immediately available. At 2, 3 in the morning, when you still have to mobilize the team, patients should unquestionably receive intravenous thrombolysis. So under all these conditions, we must continue to provide intravenous thrombolysis to our patients. The other consideration, when you touch on this towards the end of the talk, is that these data only apply to alteplase, right? So the question as to whether you should bridge with TNK, whether that's actually superior to even alteplase or direct, remains to be answered. So we start with 3 trials in Asia, and they tend to show non-inferiority. When you first look at the data, there are many nuances there. Then you had the MistraClean, no IV trial. Some meta-analyses were conducted, not at the whole patient level type of meta-analysis, but you can see that this initial meta-analysis, and here there are 2 of them, you had pretty neutral results, right? And depending on what you consider your non-inferiority margin, many people start to question, well, maybe the EVT is non-inferior to bridging. But then our colleagues from Swift Direct and Direct Safe actually said not so fast. So very recently in the ESOC, we had these 2 presentations. But even before that, it's important that we step back to, again, as Guilherme talked about, we have to understand this concept of what is the minimal clinically important difference, which for functional outcomes, specifically 90-day MRS 0 to 2, we actually consider difference as low as 1 to 1.5 or at most at 5%, very significant, right? So these trials adopt non-inferiority margins that were in the range of 20%. Okay, so we have to first understand that very well. But then when you actually add the data from Swift Direct, as it was presented here, you can actually see that nominally outcomes were actually better with the bridging therapy than with direct MT, with a difference of 7.3%. You can see that the lower limit of the one side a 95% confidence interval was minus 15.1%. When you look at secondary outcomes, there are some issues of interest here. The reperfusion was higher with the bridging therapy, but so was the rate of symptomatic intracranial hemorrhage. So good on one side, bad in another side. When you look at direct SAFE, the Australasia trial presented by Peter Mitchell and Bernard Young at the same conference, you can see again that normally the outcomes were actually better with bridging, although not statistically significant. There was, essentially a 6% difference here. And in terms of secondary outcomes, unlikely. So if direct, you didn't really see any differences, including the rates of final reperfusion or the rates of symptomatic intracranial hemorrhage, although numerically a little higher with bridging, as should be expected. Guilherme has now presented the better meta-analysis, the update meta-analysis, which actually comprises out the 6 trials that have been performed, again, without the place today. And again, when you look at the lower non-inferiority margin here, 0.79%, it looks like we are far from unequivocally proving that direct is non-inferior to bridging prior to thrombectomy. So not surprising, you have this, again, strong recommendation based on moderate quality of evidence to continue to offer intravenous thrombolysis to all patients who present to a thrombectomy capable center within the first 4.5 hours. Other than the data and what it has shown, which again, maybe better recanalization actually with bridging, maybe not, maybe a little more hemorrhage with bridging, maybe not, but the outcomes tend to be either the same to potentially better with bridging. And even in trials that didn't necessarily show higher reperfusion. And perhaps we are at the time now that you have to depart from this concept of the macro vasculature, which is what we see in an angiogram after our treatment, to better understand what happens at the micro circulation, right? And there is a paper that I think it's very thought-provoking recently from our colleagues from Barcelona, from Mark Ribos' group, where essentially what they demonstrate here, as you can see, even in patients with TK3, there are residual perfusion deficits. And these perfusion deficits seem to be more substantial when you have more passes. Okay, so even though you are achieving macro recanalization, you are having issues with micro reperfusion deficits. This actually is a well-known phenomenon in the coronary bed that has been named no reflow. And I think that's one of the potential advantages of intravenous thrombolytics, other than just this idea of pre-procedure or even post-procedure macro reperfusion that you keep looking for. Maybe there's one of the reasons why the outcomes are better with bridging than with direct thrombectomy. And one thing that I find very curious is we know a lot about this no reflow phenomenon from the coronary bed, right? But it turns out that this name was actually coined after studies, animal studies dating back to the 1960s, as you can see here, were done in the cerebral vasculature. So the non-reflow phenomenon was first characterized in the cerebral vasculature. And I think we should stay tuned for the complete trial. It was a very provoking trial, centered in Spain, where the investigators actually gave intraarterial alteplase after achieving complete or near complete reperfusion, which seems very counterintuitive, right? Maybe you are just adding the risk of reperfusion hemorrhage. But again, the idea here is, can thrombolytics actually help us in the microcirculation, things that go beyond what you see at our final post-procedure post-thrombectomy angiogram. So I'm very curious to see these results, and I think this idea of non-reflow is a concept that you need to start embracing in cerebrovascular medicine and start exploring this concept more and more. Moving now to my hope for the future, right? My hope for the future, and I'm not so sure you are there yet, is the idea that you're gonna depart from this polarized world that you live now, not only in politics, but also in medicine, where you're practicing this very dichotomized decision-making based on algorithms and guidelines, cookbook medicine, really, to understand that life is not really black and white. You have all these shades of gray, and you have to practice not the cookbook medicine, but rather a more individualized precision type of medicine where you individualize care. This is a concept that Dr. Lou Kaplan has been talking about for over 3 decades now. And he first spoke about this in terms of TIA. You have to understand what's wrong with our specific patient and look at that in the context of the overall data and literature. Perhaps you can bring that also to this issue of to bridge or not to bridge. So in the area of precision medicine, I think the question should not be, should we or should we not be giving intravenous thrombolysis to all eligible patients who present to a thrombectomy capable center prior to endovascular therapy? It's not the right question. This is a population-based question. The better question is, who are the specific patients who should versus should not receive intravenous thrombolytics when they present to a thrombectomy capable center, right? Is leaving from the concept of clinical trials and data that really analyzes population only to try to bring the patient characteristics and help us with the decision-making process. Georges and I wrote a little bit of a critique about all these trials that were emerging last year. I would invite you to review this paper. Here, what you try to do is trying to identify some factors that may sway you more towards doing a direct approach versus a bridging approach. I think we know there are factors that will define higher versus lower chances of reperfusion or benefit after intravenous thrombolysis, okay, as well as complication risks. There are peri-procedure issues that you need to consider in terms of the need of intra or extracranial stent in this patient population. There are also geographic and center-specific characteristics related to the cost of therapy or the speed of your local workflow, the availability of your team at any given time. Again, if your team is not in-house, there is no sense to have even a discussion about this. You have to bridge because time is brain. With the idea of exploring some of these individualized components, patient characteristics, we perform a pool analysis at individual level of the DVT and SCIP trials. You present this a year ago at the ISC. We call this the SHRINE pool analysis. In terms of outcomes, pretty neutral. There was no major difference. A little bit more any intracranial hemorrhage in patients with bridging, also a little more puncture site complications in patients with bridging, not surprising. But in terms of outcomes, even though you were analyzing 2 trials from Asia before the trials that actually had better workflow, right? As you know, in Asia, you had some issues with the workflow, specifically the door to needle time, right? And I think we have always talked a lot about door to needle time and door to puncture time. We are now getting to this new area where you have to understand the importance of the needle to puncture time, because the needle to puncture time is exactly the period that will give your intravenous thrombolytic an opportunity to work. So if you are centers, and this really happen a lot in Asia, where the door to needle time was relatively delayed for several logistical reasons, but they actually had very good door to puncture time. The needle to puncture time was short. And this is one of the potential reasons, okay, along with the fact that the Asian population probably has more intracranial atero, and intracranial atero may be more resilient to intravenous thrombolytics, while you see a little bit of a dichotomy between the Asian trials and the trials done more recently. But going to the results of this, we actually adopt a non-inferiority margin that was 0.85. So pretty, actually pretty liberal. And even at that point, we almost got it, but it was a 0.84. So we failed to show non-inferiority, even though you were using pretty liberal numbers here. But what I'm more curious to know about these trials is actually, again, not the overall population data, but can we dissect the different populations that may benefit versus not from the different approaches? And here we have some initial data that it's quite exciting. When you look at onset to puncture times, okay, it looks like if you have your onset to puncture less than 3 hours, you're better off with bridging, versus if your onset to puncture is beyond 3 hours, you may do better with direct MT. And the reasons for that is not only you have more penumbra, right? As you when you were earlier, this would apply to any type of revascularization, but you know now more than ever that not only you save more penumbra, but you actually reperfuse more with intravenous thrombolytics the faster you treat the patient. So I think this is pretty consistent with what I expect, and maybe time to treatment may be one of the differentiators you may be using in the future to decide as to whether or not you bridge. But again, this requires further validation from large data and in broader population. Another piece of data that I thought was very exciting is that the patients that had intracranial ICA occlusions, they did a lot better with direct MT, right? These are patients that have typically a lot more clot burden. We know that TPA for intracranial ICA occlusions, they only recanalize about 4 to 8% of the patients. So perhaps as a population that, again, pending confirmatory data, we may skip TPA prior to thrombectomy. In terms of SICH, symptomatic intracranial hemorrhage, one of the things that you notice is patients who had atrial fibrillation, okay, they perhaps do better, okay, if you do bridging, because if you don't do bridging, if you do direct, because atrial fibrillation seems to increase the risk of intravenous TPA-mediated hemorrhage in this population. Again, can see a remarkable interaction term here, but we await for confirmatory data from the larger meta-analysis, but maybe AFib is a differentiator, as you can see here, also in terms of mortality. Whereas if you have atrial fibrillation, maybe you want to go direct versus not, you then would go with a bridging therapy. So stay tuned for the big meta-analysis. Here you just had 2 trials, Asian trials, numbers that were relatively small, it's just around 500 patients. The improving reperfusion strategies in ischemic stroke or IRIS meta-analysis is ongoing, and I think it's really gonna help us better understanding if we can adopt this approach of more individualized decision-making for this specific topic. Finally, I think it's very important that you understand that these data, they were actually outdated from the start. One of the things that was striking to me is in April 2018, we already knew that bridging with TNK was very likely superior to bridging with alteplase, right? You had better recanalization rates. You even had a suggestion of better outcomes with a P of 0.04 when you look at the median scores on ordinal analysis. So it was a bit unfortunate that we start out these trials using alteplase, even though you had this knowledge. So I think there is a need now to explore the same paradigm using what we all believe might be a better drug for bridging than alteplase. We have one of these studies just started in Brazil. It's called the Resilient Direct TMK. It's done with our Resilient network in Brazil, and I suspect that many other colleagues will join us on this. So to conclude, direct thrombectomy has not been unequivocally demonstrated to be non-inferior to bridging therapy. Therefore, intravenous thrombolysis should continue to be offered to the vast majority, if not all, mechanical thrombectomy patients presenting to a thrombectomy-capable center. However, it's important to acknowledge there are many individual variables in the decision-making process that we have access to that cannot be properly considered in clinical trials. So it sounds reasonable to adopt a tailored, individualized approach, mostly if the results of the IRIS analysis confirms that this approach makes sense. Finally, the big question remains, how about bridging with TMK? Thank you very much for your attention. I'll be glad to take any questions.